I think seven at UAE. So we have quite a few of us who've joined in already. So I think I've met some of you in the last lecture on Sunday when we talked about the definition of PHVD, the post-hemorrhagic ventricular dilatation, cranial ultrasound measurements, pathophysiology, and the incidence and magnitude of problem. Today, we are going to continue with the management side of things, and I'll do that with a case just to make it a bit more interactive and interesting for everyone. I am a neonatal consultant at Brighton, UK, and if everyone is happy, shall we start with the presentation? Ranjit, you happy for me to start?
Yeah, thank you, Dr. Praveen. Welcome everyone for the next session. I think you already met Dr. Praveen before. So, and apologies from Dr. Alok's side, he couldn't be able to join today. He's stuck in an emergency. So I think today we continue for the previous lecture with the post-hemorrhagic ventricular dilatation and also how to approach the ventricular megaly and enlarging head size in preterms. That's what we're going to discuss today. We'll see how we can try and make it interactive as much as possible. Back to you, Dr. Kishore.
Thank you. Just going to share my screen. Okay. Can everybody see the screen now? Can you see the presentation?
Yes.
Yes.
Brilliant, thank you.
Yes,
and I'm just going to see if I can play the slides and whether they move. Just check. Do they move for you?
No.
Okay. Let's see. Now?
No.
Okay, so there's some issue. Let's try again. Yeah.
Yeah, now we can see the next.
I'm just checking if the slides move because can you see the slides move?
Yes.
You can now?
Yeah.
Yeah.
Okay, brilliant. Fine. So what we will do today is we'll continue with the management of post-hemorrhagic ventricular dilatation. So we talked about what is ventricular asymmetry, what happens if you have an IVH, and how severe grade 3 and grade 4 interventricular hemorrhages can lead to post-hemorrhagic ventricular dilatation. We talked about different measurements, most common Levin's ventricular index, but also anterior horn width. And we talked about thalamo-occipital distance. We talked about the different charts that we use to monitor ventriculomegaly in post-hemorrhagic ventricular dilatation, and other measures, including resistive index and third and fourth ventricle measurement. And we talked about some ratios, and then we looked at some papers where they have compared how predictive a cranial ultrasound is versus a MRI or a CT for neurodevelopment. So today I'm going to talk to you about the progression of PHVD. So PHVD can progress slowly or rapidly. 65%, which is good because 2/3 progress slowly and will stabilize or regress. However, 30 to 35% of infants will have a rapid progression in ventricular size over days to weeks. And if that happens, we'll discuss about medical management, non-surgical CSF drainage approaches, other alternative approaches, and surgical devices. So can everyone see these images, the cranial ultrasounds?
Yes.
Yes.
Okay. So the background for this baby is a preterm 24 plus 4 weeker baby born at 734 grams at a level 1 unit, had 1 dose of, mom came in labor, mom had a complex medical history, 1 dose of steroid 3 hours prior to delivery, and received magnesium sulfate. Baby was intubated and ventilated, received surfactant, transferred to the local neonatal intensive care, so that's level 3 unit. And this is a day 1 cranial ultrasound. So I have a few coronal sections and a parasagittal right-sided section. Would anyone want to comment? So we can't see a clearly large IVH, but the choroid plexus do look quite bulky, and you can see that there is some bilateral ventriculomegaly, which is a bit strange for a day 1 newborn. So we note that and continue to monitor the baby. So this was his cranial ultrasound on day 3. So he continued to be intubated and ventilated, had a large PDA. And before we treat PDA, we use ibuprofen or indomethacin. So we check for any platelet or renal issues, but also we do a head scan before we start, just to make sure that there are no intracranial bleeds. So if you look at the images, does anyone want to say what we can see on the images?
There is right
Can
ventricular.
everyone still hear me? Yeah, thank you. Go on.
Little bit ventriculomegaly. I don't know if the sizes is increasing a little bit. And if you go further, I think there is like triangular shape or hyperechogenicity of the right side. Maybe it is intraparenchymal hemorrhage.
Yeah.
And on the sagittal, also in the plexus, choroid plexus, also like a hemorrhagic infarct.
That's right. I agree with you. So we can see even in the initial frontal cuts, you can see that there's a little bit of bleed in the right-sided lateral horn of the right ventricle. And as we progress, you can see that the bleed is more clear and apparent. It seems to be filling up the whole ventricle, but it also seems to be spilling into the adjoining parenchyma. And that is confirmed when you look at the parasagittal sections, where you can see that there is blood and it seems to be organizing already. So this was a day 3 scan.
Hi, Dr. Praveen, could I please interrupt you for a while?
Yeah, please do.
Please, if you could use the pointer to delineate where the actual hemorrhage in the
Sure.
parenchymal and all would be
Sure.
great.
Can you see the pointer that I'm moving, the mouse? Does it appear on your screen or not?
No.
As of now, it's not appearing.
Okay. Okay, I think I have a pointer too, so let's see. Yeah, okay. Can you see it now?
Yes, yes.
It's moving
The
now.
pointer? Okay, brilliant. So this image is the first image where we are looking at the frontal sections in the coronal view. And this is the right side. And you can see that the lateral horn, you can already see that there is a little bit of blood there. Yeah. There is some periventricular brightness in the previous image. But as we go along from anteriorly to posteriorly, you can see the blood here, which is filling up the third ventricle, but also spilling into the adjacent parenchyma. So you can see all the blood here. So it has filled up this one. Actually, you can see a little hint of blood here in the left side as well, but it looks largely right-sided currently. Now going to the next image, you can see there is blood clearly in the parenchyma, and sometimes that hyperechogenicity is difficult to say that is this definitely a grade 4 or a severe grade 3, or is it to the extent of causing a periventricular hemorrhagic venous infarction. So I think I would definitely say a grade 3, maybe a grade 4 bleed with a periventricular hemorrhagic infarction developing here. So this was the situation on day 3, and quite unfortunate when if we...
Can I ask something?
Yes, please.
Is it usual to see unilateral grade 3 to 4 in a preterm baby? Usually it is bilateral. If it is unilateral, it is not reason suspicious that maybe this is a stroke, not an usual IVH for a preterm?
I agree that it may be more common to see bilateral bleeds. That said, it is not uncommon to see unilateral bleeds. So I wouldn't agree that every unilateral intracranial or intraventricular bleed in a preterm newborn, especially at 24 weeks, I wouldn't worry too much that is it an arterial or a venous thrombosis or a stroke. So no, you can see unilateral bleeds, and you will see as we see the progression that it's not exactly unilateral. It's the right side is more affected, but the left side seems to have some changes. And when we see the next few images, we'll start to see that there was some more blood on the left side as well. We'll go to the next slide. So this was day 12. And by now, you could see that there was a significant ventricular dilatation starting already. You can see that the lateral ventricles are significantly dilated. They are opening into here at the level of Monro into the third ventricle. There is a VI calculation that has been done here, and you can see that the third ventricle appears to be slightly more prominent. You can see that the blood has not resolved completely. It is day 12. Now I know that Dr. Alok talked to you about IVHs, and the usual course or progression of an intracranial bleed can take 2 to 3 weeks. So sometimes you will find some resolving bleed or some remnants of a bleed up to 3 weeks in the ventricle. You can see that there is some blood left here and maybe a little bit on the left side as well. You can see some blood here on the left, and you can see that on the right, there is a grade 4 where it is spilling into the adjacent parenchyma. We talked about RI, if you remember, how a developing PHVD can affect cerebral perfusion. So you can see that there's pulsatile flow here. Systolics are high, but you can see absent end diastolic flows here. And that is giving rise to a resistive index, which is quite high, 1. I have to say that this baby did have a large PDA, which was treated with paracetamol, but that could also be contributing to the lowered cerebral perfusion pressures and reduced end diastolic velocities. And on the right, you can see that there is blood, but it is starting to organize here in the lateral ventricles.
Doctor, is it okay if I can ask a question about the previous slide?
Yeah. Yeah.
I just feel I'm not sure, the area around the ventricles are a bit hyperechoic. Could it be ventriculitis also?
Sorry, I did not catch that question completely. The last part, can you repeat that again for me, please?
The area surrounding the ventricles, it looks hyperechoic. Is there a chance this can be ventriculitis as well?
So it is very important to know your machine. Very good question. Very good question, because yes, when we call it the panda eye sign, when there is a brightness of the ventricles, surrounding the walls of the ventricles, when they appear bright, that appearance has been called raccoon eyes or panda eye appearance in cranial ultrasound, and that can suggest ventriculitis. That said, I know that in our machine, the settings so there are 3 probes that we use, and the settings that have been used on this probe, you can see even rest of the images to be quite bright. And that's why I think if we go back to the physics and to the, how to optimize your cranial ultrasound imaging, it's quite important to use, to make sure that the gain is optimized, that your probe, these days we use a Philips machine and it has a button which says eye scan. So if you press that, it will bring you automatically to the optimum setting for a cranial ultrasound or for an echo or for a vascular scan. So the other way to differentiate would be to look at the clinical picture, to look at what is the CRP doing, what is the white cell counts doing. So I take your point, very well picked, that the brightness of the walls of the ventricles can point out that it is ventriculitis. However, here it was, and you will find in intraventricular hemorrhages, you will find an enhancement of the walls of the ventricles. So this was not a ventriculitis, but I agree you should always keep an eye out for ventriculitis. Shall we go to the next slide?
Yes. Thank you, doctor.
Okay. So now ventricular dilatation slowly increased, and we had to make a referral to the neurosurgical team on day 21 for advice regarding therapeutic taps and further management. Our team said, yes, try a therapeutic lumbar puncture. And the problem with therapeutic lumbar punctures, like I discussed in the last last lecture, was that often in the very preterm babies, it's very difficult to aim for 10 mils per kilo or 20 mils per kilo. We got 4 drops. So absolutely no change, very minimal amount of CSF drained. We talked to them about, should we try a ventricular tap? I will today talk to you about why ventricular taps are a problem. So they said, baby is stable, yes, but no need, don't do a ventricular tap, but do a MRI. Now, I'll just to wake everyone up, if I'm boring you. If you remember at the beginning of this lecture, we said, what percentage of post-hemorrhagic ventricular dilatation starts regressing or resolving on its own, roughly?
35%?
Yes, well done. So exactly. So sorry, 60 to 65% resolves on its own, and 30 to 35% will keep progressing and will need more, intervention. So on day 28, we asked for an MRI, and baby was ventilated. It was not the easiest to get a MRI. So by day 28, it started showing a bit of reduction on the VIs. We started doing twice weekly cranial ultrasounds. And if you remember my discussion last week about VIs, anterior horn width, and temporal occipital diameter, because we talked about how VIs can sometimes fool you. So VIs are stable, but the head circumferences are rising. So this is the day 21 scan. You can see that the measurement that was done here, and it is also very operator dependent. You will see that I could give you a VI of 1.53. Someone else can come and measure the same thing in a slightly different plane and make it a bit larger. So there was apparent reduction. But if you look at the ventricles, you can see a bit of rounding here. And when you see rounding, what would be the best? So rounding sort of tells you that there is developing hydrocephalus, but also what would be a good measure to use instead of VIs?
Interior.
Yes, exactly. So anterior horn width would be a good one to sort of have measured here, because you can almost see, and it stays static for whatever gestation you use. So I've not been able to sort of measure because this was an image already taken and I couldn't modify it. But it will give you an idea of, is it a moderate dilatation? Is it a severe dilatation? So it gives you additional information to decide or to inform the neurosurgeons that we are worried. If you look at the dilatation, it's massive. It's already starting to press on the white matter. You can see huge, and if you did a thalamo-occipital diameter, that would also be huge. However, neurosurgical teams, their thresholds are quite high. They said, keep observing. We kept on doing scans. Now look at this at 6 weeks. How does it look? Does it look worse, better, same?
Resistive indexes are better. The
Yes, I think
diastolic flow has started and the dilatation has stayed almost the same only.
yeah, it might even be a bit less, isn't it? If you look at the dilatation, it doesn't look as, I'll go to the previous slide. You look at the dilatation here, where it almost seems like it's occupying whole of the brain and there is very little white matter left, versus a couple of weeks later, these VIs, and you know that VIs are gestational age dependent. So as you go up, the VIs should also go up. So these measurements were fine. They started showing a reduction. So they were in between the 97th and the 97th plus 4 centile. You see that there is still a little bit of blood or hyperechogenicity in the right side in the parenchyma. We did a thalamo-occipital diameter, which is the most sensitive measurement for development of hydrocephalus, and it was significantly increased. If you look at the right and if you look at the left, you can see the problem with thalamo-occipital diameter. Because if you remember last week's lecture, because unlike coronal sections, we know where to measure VIs and where to measure anterior horn width. In the thalamo-occipital diameter, there is a lot of variation. So you can see how the right is 3.15 and the left is only 2.59. And it does not appear in the same way. So the way your scan has been done, or the way you have measured it, can make a significant change. So if you are measuring thalamo-occipital diameter, remember that here you should have a little bit of choroid plexus, and then make sure that the head is in midline so that you get similar images. Otherwise, the ventricle on one side might appear to be smaller than the other. RI has improved. So yeah, it looks slightly better, slightly reduced. And so we kept on doing PIs and we kept on sending these measures, and the neurosurgeons were like, yeah, it's stable. Nothing needs to be done right now. Do a MRI at 15 weeks. So we did a MRI and they reviewed these images. You can see that there's a fair amount of ventricular dilatation. We send our MRIs to a neonatal neuroradiologist who predicted that there was compression of white matter in the region of corpus callosum and the region of thalamus. And she did predict that there is a chance of significant motor and cognitive morbidity in the future. This baby had chronic lung disease, had a lot of other issues, needed multiple episodes of ventilation, and we couldn't just wean him. And finally, we found a genetic diagnosis of primary ciliary dyskinesia on genetics. So he had a tracheostomy cited and he had long-term ventilation. Neurosurgeons were happy for no intervention. And at about 26 weeks after he was born, he was transferred to the Children's Hospital to the pediatric respiratory team. I actually met this child 2 days back. He's 1 year old now. He has not had a neurosurgical intervention and he's doing okay. So that was a case study. and I will go to some theory now. So the first management that we used to try, it's not as popular anymore, is medical management of PHVD. There was this concept that diuretics cause reduction of production of CSF, so furosemide, and I have used a lot of acetazolamide when I practiced in India, especially for tubercular meningitis and hydrocephalus caused by tubercular meningitis. But the studies comparing use of furosemide versus acetazolamide versus conservative treatment versus LP showed that you may have a reduced need for a VP shunt, but mortality increases and neurodevelopmental outcome is worse in the group that receives diuretics. It almost sounds like if you keep giving diuretics, the baby will not need a VP shunt, but will either die or will have very poor neurodevelopmental outcomes. So I don't think it's great. It's a great advertisement for furosemide and acetazolamide in PHVD. So it is not recommended to and it is a level 1 recommendation that is not recommended to reduce the need for shunt placement in infants born preterm with PHVD. Then going to non-surgical management. There are serial LPs that you can do, and they relieve the pressure from the CSF and remove debris. I am interested to know what is your practice, because I'm sure you might be coming across some IVH and some PHVD because of it. Any experiences of serial LPs, how helpful they are, how easy they are to perform? Anyone?
Yeah, we are used to do serial tabbing till the neurosurgeon decide to put Omaya reservoir, and after that we just do the scanning to see if we indicated for tabbing or no, pre and post tabbing, and to some point it is still the same. We are doing tabbing like 3 times per week, so we'll consult again the neurosurgeon, and at that time they will put the shunt if the protein less than 2.5 gram.
Okay. Thanks, Dr. Nashwa. I think I remember that last week when we were talking, you said that you use ventricular tap sometimes, and we will talk about the evidence and behind it and what the risks and benefits are. So I have found serial LPs to be quite difficult, especially if you have a 24, 25, 26 weeker. 3 people have tried 5 times and you've got 5 mils out, which is basically 2 mils or 3 mils or 4 mils per kilo. And at least a minimum of 10 mils per kilo of CSF and up to a maximum of 20 is needed to make sure that there is a reduction in ventricular, in reduction of intracranial pressure and reduction of ventricular fluid. So we will talk about what Cochrane says. So if you tap and as a result of your LPs, if VIs and anterior horn width reduces, then you can continue to do weekly ultrasounds till 32 weeks. However, if repeated LPs are necessary, you will have to refer to the neurosurgical team for insertion of a temporizing shunt or a temporary shunt. A Cochrane review in 2017, and this was done by a colleague of mine from Bristol, they found that there is no benefit of lumbar puncture over conservative management to reduce disability or need for VP shunt surgery. So I think it just I think the Cochrane reviews often say no benefit because there is not enough evidence. So that is the evidence. That's the last Cochrane review on LP for reduction of VP shunt surgery or to reduce disability. It says no benefit. Ventricular tap is quite interesting. I think it looks very tempting. You can get that fluid out, but clearly you are directly accessing the ventricle. There is a huge risk of CSF infection and loculated hydrocephalus. So I think we have to be very, very cautious. And ventricular taps without a Omaya or without a reservoir or without a ventricular access device is almost unheard of in the UK. Very few units would do it on a routine basis. So these were, non-surgical management. There are a few alternative approaches. So has anyone heard of the DRIFT trial?
Yes, you mentioned in your last session.
Okay, so this is the drift trial. This was largely done again in by the neurosurgical and neonatal teams. Started at Bristol, but a few other units were involved as well. So what they did was, if they found that there was a intraventricular hemorrhage, a significant one, and there was post-hemorrhagic ventricular dilatation, they would drain it, irrigate it with an urokinase or an anticoagulant, so a fibrinolytic, and try to wash away all the debris and all the blood. The idea was that the debris is what causes trouble. It blocks everything. As we remember in the pathophysiology, that is what causes progressive hydrocephalus. In the short-term outcome, the study had to be stopped early. They only recruited 77 because they were giving fibrinolytic. These were preterm infants, and they started having excess secondary hemorrhage. So 35%, that's a huge number. Almost 1/3 of the babies had some kind of secondary hemorrhage. These hemorrhages were small, and they continued to irrigate, but they stopped recruiting anymore. So they continued the drainage and irrigation. Death or severe disability, drift arm had less deaths. I do not know whether it was statistically significant, but it was 54% versus 71% in the standard treatment group. Now you have to remember this study is from 2007 to, it started in 2007, 2008. So
Your voice is gone.
You are mute.
We lost you, Dr. Praveen. Can't hear you.
yes, no,
Yes, I can hear now.
good. So I'm just going to put the volume up to full. So yeah, among the survivors, however, they found that there was a significant difference. Almost double the number of babies who survived had, if they were in the standard treatment group, that is, if they had not had the drift, they had severe cognitive impairments. And at 10 years of age, again, they found that the mean cognitive development was much better in the drift group. So following adjustments for all of those things, they felt that the drift group children were alive without severe cognitive disability. And quite a significant number. So long-term outcome was much better, and it supported their hypothesis that washing out harmful substances from ventricles will reduce overall brain injury. The problem, however, is that there are very few units, and it needs a lot of expertise to be in the right place to be doing the irrigation. They have themselves written in their paper that it almost is like performing ECMO. So you need that kind of expertise to be able to give that. And in the UK, I think there were 3 or 4 centers who could do it. So although there is a clear benefit, I don't think many units are doing it anymore. There were other places which did the same study. I think there was one study from Korea which used another fibrinolytic and called it the ventricular lavage therapy. So just for you to know. So now we're coming to the next. So we've talked about alternative approaches, but now we are talking about temporizing measures, how to buy some time before you put a definitive shunt, because a definitive shunt can be put only in a larger baby, 2.5 kilos, has its own problems, is not free of problems. So neurosurgeons are not going to put a ventriculoperitoneal shunt right away. So one of the things that you can do is put a ventriculo-subgaleal shunt. So basically coming out of the ventricle, lateral ventricle, and going into the subgaleal space. As a result, anytime the pressure increases, fluid flows into this subgaleal space. So you will see the subgaleal space become bigger. There's enough space because that space is really compliant. So decompression can happen without need of frequent tapping
Because it's a closed system, the CSF gets absorbed slowly. It does not cause any electrolyte abnormalities. And there is no risk of, the risk of infection compared to other ventricular access devices is much lower. Of course, putting in a catheter has a risk of infection. The other problem is that you can't control drainage. So if the pressure is high, sometimes a lot of CSF can just drain in. And occasionally, because of the procedure, you'll see CSF leak. Then the other option is ventricular reservoir or ventricular access device. So here, the catheter tip is here in the lateral ventricle, and the distal end is connected to a silicone dome that is again in the subgaleal pocket, but what it does is it does not allow it to flow automatically. So you can control how much CSF you want to take out. So it allows serial CSF aspiration. So this is just after having the surgery done. It is tapped using a 25 gauge, you can use a butterfly. You put the butterfly needle into this subgaleal reservoir. It's also called Omaya. I think there are different types, or I think there is I have used Omayas, but I'm sure there are different names to it. And then you can connect your syringe. It has to be done in very sterile and aseptic manner because you are going to introduce a germ and then the baby will die of meningitis. So you have to be really careful. But it does allow full provider control over the volume removed, and you can choose how frequently you want to drain. So it gives you a good temporizing measure. While you're waiting for the shunt to be put in, sometimes they will not need a shunt at all. But the risk of infection is much higher as compared to the ventricular subgaleal shunt. The other problem is that every time you're poking this baby with a needle and you're sat there aspirating for 10 minutes, they are facing pain. So this is a comparison of complications associated with ventricular reservoir versus subgaleal shunt. And you can see that subgaleal shunts are more prone to obstruction. Ventricular reservoirs seem to be slightly more prone to infection. You might need to revise subgaleal shunts slightly more, but they seem to be quite similar. When I looked at the numbers, I couldn't really pick one over the other. The only benefit of a ventricular reservoir is that you can tap it when you want to, whereas a ventricular subgaleal shunt does not have that advantage. So there have been other studies, and they saw no difference between ventricular reservoir and ventricular subgaleal shunt in rates of infection, CSF leak, death, or the rate of ventricular peritoneal shunt needed. This I have not seen being done, but I know that some units and some neurosurgical teams do like to put external ventricular drainage. And basically a catheter is introduced and it is connected to a closed drainage system. It looks very complicated to me, and I have not used it, but I'm happy to hear from any colleagues here who have used the external ventricular drainage. Okay, so I guess
The risk of infection is very high in this procedure.
Sorry, Dr. Nashwa, I couldn't hear you clearly.
The risk of infection is very high in this one.
Yeah.
I saw it 2 times only in the past, like more than 15 years ago.
Yeah, I mean, clearly it looks like you have a closed drainage system, but it's prone to infection like anything, because your CSF, your ventricles are open to a system which can be prone to infection. So I found it really, I have not used it ever. So
I saw it.
okay.
I saw it in the past.
It does say that it has some benefits, and in 30 to 40% cases, it can resolve PHVD. But as I said, it is probably depends on the neurosurgeon and their experience. So
I think they are used in the emergency only, and I saw it in one pediatric baby, not the neonate.
Okay. Yeah.
in emergent with high intracranial pressure, so they have to relieve the.
Okay. Yeah, that would make sense.
But
If it is a
but
temporary,
in unit, no, I think no.
yeah, if it's a temporary thing to relieve, intracranial pressure, it makes sense. But as a long-term thing, I think it's very tricky to think about it. Now, I was going to talk about timing of when do you intervene, when do you tap CSF, when do you put a ventricular device, and there has been a lot of discussion about this, early versus late, CSF tapping through lumbar puncture or through reservoir or even shunt. And this was the Elvis trial, which is early versus late ventricular intervention study. They included 126 preterm babies, less than 34 weeks with progressive PHVD. And they put them into two groups. So one group was a low threshold group where VIs of 97th percentile and anterior horn width of more than 6 millimeters. Or TOD more than 25 millimeters. And if you remember the charts, these are all on the lower end. So basically they're saying that don't wait for it to expand or dilate anymore. Just go for it. Just start draining. Whereas the higher threshold was what we use, and I guess most of the units we use. So anterior horn width more than 10 millimeters, that is severe dilatation. And Levine's index 97th percentile plus 4 mm and above. So that's again a higher threshold. They did not find any difference between the two groups for death or VP shunt. So irrespective of whether you do it at a lower threshold or you do it for a higher threshold, similar numbers for death and VP shunt. However, there was a slight difference if you look at percentages, and I do not know when you have just 126 babies, how much you can look, how much you can see into it. So 30% versus 37% for higher thresholds. They had very few babies who needed the shunt at the end. So just about 19% infants in the low threshold and 23% infants in the high threshold group. However, the lower threshold group needed more neurosurgical interventions. And that sort of makes sense because if you have started early, clearly to get to the point of VP shunt, you will probably need to have more than one reservoir or more than one ventricular access device. So the risk of developmental impairment was low amongst both groups. So no clear difference between either of the groups. No significant difference for CP, cerebral palsy, developmental test score less than 70. And I think conclusion was that if you do a timely intervention to reduce the ventricular dilatation, it will reduce the brain injury associated with ventricular dilatation. I don't think there was a clear conclusion here. So now, finally, you've tried everything, and then the neurosurgeons have to put in a ventriculoperitoneal shunt. Approximately 60% of infants who have been treated with a temporary procedure will still need to go on to long-term shunt. 40% will have no further progression. So VP shunt, some places will do it at 2 kilos, term baby. Some places will want to have a bigger baby. Also, and this shunt then goes into the abdominal cavity. If you had abdominal comorbidities like NEC or has a stoma or some intestinal problems, sometimes you can put it into the atrium, so ventriculoatrial shunt. And in the bigger children, they will sometimes put it into the pleura, so ventriculopleural shunt. It is said to be a long-term neurosurgical management, but you can see that it's not free of problems. So one, there is 5 to 10% risk of shunt infection, especially during the first 6 months. It is that period is really troublesome. There is lifelong risk of obstruction, migration, and fractured tubing. And I guess all our colleagues who have worked in non-European countries where we have seen infections causing meningitis and hydrocephalus, I'm sure we've all seen obstructed VP shunts, migrated VP shunts, broken VP shunts, and how they had to keep coming into the hospital and needing neurosurgical procedures to revise it. So they say that almost half of the children who have had shunt will need at least one shunt revision by the age of 2. So I have today tried to capture in my slides just the different modalities that we can use to manage VP shunt, to manage IVH, and followed by PHVD. We have tried to talk about the evidence behind it. We have tried to talk about alternative approaches, and we have tried to discuss a case of PHVD, which was monitored with MRI, with head scans, but at the end, the child seems to be doing well and did not need a surgical procedure. So that's all I have for you today. Thank you for listening so patiently. I'll go back to Dr. Ranjit.
May I ask one question, please?
Yes, please. Yeah.
Thank you very much for this wonderful presentation. So just one question about how many times should we repeat the serial LP or tab, spinal tab before decision to take the baby for VP shunt?
I think if I have to be brutally honest, you are at the mercy of the neurosurgeon, and it depends on the neurosurgeon's threshold. Ideally, they say that twice weekly ventricular drainage of CSF. If you have a reservoir, it becomes very easy. If you don't have a reservoir, then sometimes you are doing it twice, you are doing it 2 to 3 times a week. And the volumes that are targeted are huge. They are like 10 to 20 mils per kilo. So if you have a 1.5 kilo baby, or say even a 1 kilo baby, getting 10 mils of CSF, I think it is quite tricky. It's not easy. So yeah, I think the answer to that is largely how the VIs or how the ventricular dilatation stabilizes. Sometimes you may do it twice or thrice for a couple of weeks, and the ventricular indices stabilize, the thing starts reducing, the dilatation starts reducing, and then you may not need a procedure at all.
If I can add to that, probably if you remember from my last presentation, I can share my screen for a second.
Sorry, I can't.
Can I share my screen for a second?
Yes, please. I'm just going to end slideshow. And have I stopped sharing yet? Let me just check. I will. Yes.
Can you see my screen?
Yes, we can.
Yeah. Probably might have come across this like this one. So like dividing the ventricular dilatation hydrocephalus into different zones: green zone, yellow zone, red zone, where we take into consideration the ventricular index, anterior horn width, the head circumference, sutures, bulging fontanelle, all together plotting on the centiles. That will sort of guide us where to go, how frequently to scan, how frequently to do drainage, when to go for neurosurgical. I think I've shared this presentation to all of you if you get the chance. If that makes sense, answers your question.
Yes, thank you.
Can I ask a question?
Yes, please.
Yes, sir. So like initially, so the progression is like suppose we have a case where ventricular dilatation is going on increasing, we have performed some drainage, and then gradually neurosurgeon puts in a ventricular drainage device, probably an Ommaya reservoir, and then gradually once after some drain, if the sizes starts to reduce, then they will remove that reservoir. Is there
Yes.
any guideline that they have to remove it after stabilizing of the ventricular sizes, or they have to wait for like 6 months to 8 months to monitor the child, see the outcome, neurological?
Shall I take that, Ranjit?
Yeah, go on.
Yeah, I think, you know, it is a new, even putting reservoir is a neurosurgical procedure. So I'm sure the neurosurgeons will not want to take it out till they are absolutely happy that the ventricular sizes are definitely not increasing and that they have definitely got stability. I do not know of any guidelines. I think they will be guided by MRIs or CT scans to see how is it progressing, and only when they are sure. So I think 6 to 8 months probably sounds like a reasonable period to me. From my experience, the babies who had Ommaya reservoir, I remember them having had it for at least 4, 5, or 5 to 6 months. And only when everything, but I think the ones that I saw with ventricular reservoir, if you remember the numbers I was showing you, 6 out of 10 will need a VP shunt. So only 3 or 4 out of 10 who have had a reservoir or an access device will escape the VP shunt. But if they escape, I think it will still be 6 to 8 months before they agree that, okay, fine, it's so absolutely fine, let's take it out.
Thank you.
Any other questions? Any other variations of practice that you see in your day-to-day practice? I mean, we are also learning from you, and I think everywhere has a different kind of practice. It depends on what facilities we have, what is your access to neurosurgery, what's your access to imaging. So anyone else who does things very differently?
Yeah, you mentioned that 6 out of 8 will need a shunt.
6 out of 10, yeah, 65%. If you have
6
had
out of 10.
yeah.
For me, everyone having Ommaya reservoir end up by shunt after that. I didn't see any baby.
Yeah. I think I agree with you that the ones I remember, for some reason, 10 years back when I started working in the UK, I saw more babies having VP shunts, and now I don't see as many. So something is working. Either the approaches to reduce IVH is working, but I don't see as many reservoirs and I don't see as many shunts being put in. This child that I have mentioned to you, over the last 3 years in my unit, this is the only child who we had to talk so many times to neurosurgery. And I have had shunts put in because of congenital hydrocephalus, but for post-hemorrhagic ventricular drainage dilatation, I think things are getting better, is my feeling. But that's just my unit and personal practice.
So better to wait and see, or to be late intervention than early intervention.
I think it depends on, you will have to be guided by your neurosurgeon, isn't it? Because you can tap, there is a huge risk of infection. So I think first, do no harm is really important. You do not want to harm your patient, and you can closely watch them. There are other clinical measures as well. So if you think that ABCs are happening, or if the sutures are looking very separated, or if it looks like the white matter is getting compressed, all your things are just going off the roof, then, and then of course, as I said, the neurosurgeons are the ones who decide. You can press upon them. Some people have a more relaxed threshold. They will let the head grow and see how things go. Others will intervene and put a reservoir.
Okay, thank you.
Yeah, probably I agree with Dr. Praveen, and my experience has been pretty similar with the number of cases we see. The number of cases are coming down. Again, we are pretty much guided with the surgical colleagues for this management, as we all see regularly. One of the few things, complications we came across with the Ommaya reservoir for long term is the skin necrosis. As the head grows, the skin gets more tight, and that's one of the reason either they remove it or whether they switch to the more long-term like a VP shunt. So I don't know how frequently you have seen in Maya river causing like a skin necrosis at the point of the puncture. And other thing,
Yeah, I've definitely seen skin infection happening because people are puncturing it very frequently. I have not seen skin necrosis, but it makes sense absolutely that that risk is definitely there.
And obviously, like we are also guided by the CSF protein and when to shift to the VP shunt. when the protein is coming less and less, and less RBCs in the when reservoir tap CSF and frequency of the reservoir taps that we need to do, then they go for the inhibition. Right.
Brilliant. I think if there are no more questions, shall we bring this to a close?
I think we are closing early today.
Yeah, I'm on the unit. I've just been
Yeah,
looking
yeah.
behind my back. So thank you very much, everyone, for patiently listening. And yeah, bye everyone.
Thank
you,
you
Dr.
for a
Praveen.
beautiful
you.
thank you for a beautiful talk.
Thank
It
you.
was very informative. Thank you.